I'd like to introduce our speaker today, Dr. Lynn Deitrick. Dr. Deitrick is a clinical educator for the Florida Caribbean AIDS Education and Training Center. She has more than 30 years of healthcare experience, spending the last 13 years as a nurse, educator, researcher, and writer. Dr. Deitrick has developed and presented educational sessions for topics on HIV, spoken at national conferences, and previously prepared 2 online educational modules for hospital staff. In addition to her wealth of knowledge and clinical education experience, Dr. Deitrick has published 25 peer-reviewed journal articles. She holds a doctorate in applied medical anthropology from the University of South Florida. Dr. Deitrick, I'm going to turn it over to you for today's session.
Thank you very much, Suzanne. It's my pleasure to speak to you today on this most important topic. So let's get started. The objectives for today are that by the end of this session, you'll be able to define culture, explain how culture impacts a person's worldview, discuss the CLAS, which stands for Culturally and Linguistically Appropriate Services and Standards, and describe how to integrate CLAS standards into professional practice. I also want to let you know that this is the first of a 2-part webinar series on cultural awareness. The second one will start where this one leaves off, so I hope you'll join us for that one. Okay, so culture is what separates us from our closest relatives, the great apes. There are multiple definitions of culture out there, but I like to keep it simple. My definition of culture is the customs, traditions, beliefs, and language shared by a group of people. You can also have subcultures, including organizational culture, regional cultures, association cultures, and on and on and on. But keep these 4 components in mind as we move forward with this session. Here's an easy-to-remember definition for culture: the things that bind a group of people together. Geography can play a role as well. People from the same area or same country may share some or all of these components, but not always. You can also have organizational culture, professional culture, such as medicine, nursing, social work, things like that, each with its own customs, language, beliefs, and traditions. As I mentioned earlier, it is culture that distinguishes us from our closest relatives, the great apes. So what happens when you put on your sunglasses? Many of us probably wear sunglasses outside in the sun. Think about what happens when you put on your sunglasses. Things look different. Of course, the sunglasses affect the way you see things. Sunglasses impact your view of the world. Think about this sunglass analogy when we talk about the concept of worldview. Worldview is influenced by culture. We all view the world in a certain way based on how we were raised and where. Worldview is a critical element to remember as we talk about cultural awareness. As I mentioned a few minutes ago, worldview is an important concept when we talk about culture because we all have been brought up in one culture or another. For example, those of you raised here in Florida, think about what it was like growing up here. Think about how you would describe Florida or Southern culture to someone outside of Florida. Words that come to my mind include hospitality, friendliness, welcoming, and you probably can all come up with many more yourself. My family is originally from Pennsylvania. And for those of you that have been there, you know that people who are native to Pennsylvania often tend to be taciturn and keep to themselves. And there's a lot of Germanic influence in that state. The taciturn nature of many native Pennsylvanians could be off-putting for newcomers. Pennsylvanians really are nice people once you get to know them, but it takes time to get to know them before they'll open up to you. This is very different from Florida, where people are welcoming from the outset. Similarly, some of you may have been born outside of the U.S. Think about how you would describe the place you were born to someone who hasn't been there. Think about the key words you would use in this description. For example, taciturn, warm and welcoming, hugs, friendly, and we could go on and on with words. Worldview doesn't change. This is the basics of what we believe. Worldview impacts how we see the world and make judgments. It's not based on skin color, but on culture. The concept of lived experience is also important to keep in mind when we talk about worldview. One needs to experience something to really understand it. As an example, let's use disability. Unless you've ridden a wheelchair, you can't begin to know what people who use a wheelchair are living or experiencing. The language you speak at home impacts your view of the world. For example, if you speak a language that has words classified as masculine or feminine, this can impact your views on gender and conceptions about gender. If you speak a language like Navajo, you might tend to view your world in terms of dimensions. For example, in English we would describe a water glass as a glass that holds water or other liquid. If you were Navajo, you might describe the same water glass as a clear sphere that holds liquid. Do you see the difference in the descriptions? In English, it's a glass. In Navajo, it's a clear sphere that holds liquid. Obviously, from this example, Americans and Navajo see the world differently or have a different worldview based on their language. Similarly, language can impact your perceptions and understanding of the world. Let's use the example of the nuances of color. Two famous linguists, Lynn and Kay, wrote a book about color terms and how they're used around the world. As an example, some languages of people who live in tropical areas may have multiple words for shades of green, whereas in many Eskimo languages, green is just one word with no words for variations in shades of green, since much of the Eskimo world is snowy most of the time. Eskimo languages tend to have multiple words for types of snow, whereas languages of people from tropical areas may not have a word for snow. These are just a few examples of how worldview, particularly language, affects who we are and how we see the world. Think about it. How would you explain snow to someone whose native language doesn't even have a word for snow? Language can also be a barrier if we don't speak the language of those around us. This is a major problem in our country. We have lots of people who speak different languages who may not be proficient in English. Similarly, there are professional languages such as the language of medicine or science. For people who don't speak medical, for example, the language and words can be a mystery. Think how this can impact us in our work. Language can create barriers for people seeking health care, among other things. The next topic we're going to talk about is enculturation, and we sometimes think of the word tabula rasa, or blank slate. In thinking about worldview and language, we also need to understand the concept of enculturation. Think of it this way. We are a blank slate when we're born. We are enculturated as we grow up in the culture we live in. We learn the language, customs, beliefs, and traditions of our culture from those around us. We grow up viewing the world through the lens of our native culture and language and think this is the best. Similarly, we are enculturated to the culture of our workplace or profession and learn the language and culture of those also. Many people who come to our country from somewhere else have different worldviews and languages based on where they were raised. We need to understand that our patients may have very different customs and languages than ours and view the world differently. Ethnocentrism is the belief that our own native culture and language are the best, and that every other culture and language is inferior to our own. What's wrong with this view? Would you want to be treated as though your culture and language and you are inferior to others? Of course not. Yet many of us unintentionally probably feel this way. It's natural to think that your way of doing things is the best, or that your language and customs are the best. Cultural relativism is the belief that other cultures and ways of doing things are different but equally valid. This is the opposite of ethnocentrism. Adopting an attitude of cultural relativism will lead to better communication and trust. This concept of cultural relativism is at the heart of cultural awareness. We need to learn about other cultures in order to interact effectively with our patients and with each other. Cultural awareness education can help. A cultural construct is an important term in the study of cultural awareness. Many cultures have their own ideas about life, health, and spiritual matters that have been handed down through the generations. These cultural constructs sometimes differ from scientific, so it's crucial to learn what people understand about health and illness in order to effectively help them achieve improvements in their health. As you will learn, not everyone believes in the Western biologic model of disease causality. Many cultures define illness and health in different ways, such as the body forces being in or out of balance, or the spirit is moving you and causing a problem such as a convulsion. Mental illness may be due to a heightened ability to talk to the spirits, and so forth. Some of us may have heard our grandmothers or our mothers tell us not to go out with wet hair or we'll get sick, or we may have been told don't walk across a cold floor in your bare feet or you'll get sick. These are all cultural constructs about illness causation. There are also concepts such as evil eye, where someone looks at you wrong and you can get sick, or illness is due to God's will. The spirit moves you and you fall down, and other things. We will discuss some of these today, and more will be discussed in the second webinar in this series on cultural awareness. An explanatory model refers to how people from different cultures explain things around them. Here in the U.S., we use a scientific model for explaining the phenomena around us. Different cultures explain the same phenomena differently. Let's use the example of rain. In Western culture, we use the scientific model, and we say that rain is due to atmospheric conditions. If we were from a culture that had a religious causation for things, then we would say that rain is caused by God, and God makes it rain, so we would pray if we want rain. If we were part of the Navajo tribe, then we would say the spirits of the ancestors who live in the clouds make it rain. So if a person is raised with one belief system, it's difficult to change their worldview. So let's look at explanatory models for illness. Most cultures also have explanatory models for illness. An example of an illness explanatory model is epilepsy. And we're going to use the Hmong perspective. Hmongs are mountain farmers from Laos in Southeast Asia. During the Vietnam War, many Hmong helped U.S. troops, and as such were in danger once the war ended. Many fled to refugee camps in Thailand and were eventually resettled here in the U.S. during the 1980s. We're going to briefly talk about the Lee family, who were a Hmong family resettled in Merced, California. One of their 19 children, Leah, had seizures, so they took her to the local Hmong healer, who told them that her seizures were due to the spirit catching you and you fall down. The healer gave them traditional remedies to use for Leah and also consulted the spirits. Leah was eventually taken to the hospital where doctors diagnosed her with epilepsy. The doctors gave Leah's parents prescriptions for seizure medicine to control her epilepsy. Her parents did not fill the prescription, preferring instead to have Leah treated by the local Hmong healer. Eventually, Child Protective Services got involved, and the child eventually died from an epileptic seizure. This is a tragic but true story about cultural disconnects. Hmong explanations for epilepsy as spirit causation versus Western medicine. The doctors didn't understand Hmong culture, and the Lees did not understand Western medicine, but both wanted to do what was best for the child. The book that details this story is excellent, and it is a must-read for people who really want to understand how important cultural awareness training is. The book is called The Spirit Catches You and You Fall Down. It was this book and the story of Leah Lee that helped showcase the importance of cultural awareness training for healthcare professionals. Another example I want to talk about in terms of illness causality is the example of diabetes among the Zuni. This is a classic case of an illness explanatory model as an indicator of a public health issue. The Zuni are a group of Pueblo-dwelling Native Americans living in New Mexico. For years, it has been well documented that the Zuni had alarmingly high rates of diabetes for the relatively small size of their tribe. When asked, the Zuni said that diabetes was due to bad water in their Pueblo settlements. The state health department sent a team of public health professionals to the Zuni settlements to further investigate these high rates of diabetes. They looked at the water system, ran tests, and talked to the Zuni people. The people said the water tasted bad, so for years they drank soda instead of water. Tracing settlement records, it turned out that in 1965 the water system changed, which coincided with the beginning of the diabetes problem. In this example, it turned out that the Zuni were right. Bad water was causing diabetes. People were not drinking water, but were drinking other things, primarily soda. The public health team consulted with the tribal elders and got the people to agree to switch to drinking diet soda or bottled water, which they did. Once this happened, rates of diabetes began to drop dramatically. The careful investigation of this and the search for a solution resulted in better health for the tribe. But the reason why this example is so important because it showed that the government was really trying to understand the Zuni explanations, and the Zuni wanted to get their health improved. So they came to an understanding that was mutually negotiated, and it turned out to be very effective and benefited in better health for the Zuni. So let's talk a little bit about folk medicine. Many cultures have folk medicine traditions. These can include spiritual cures, medicinal plants, potions, and other things that are believed to affect a cure. These often exist alongside the scientific or medical systems. These cures are often tied in with the explanatory model of the problem the cure is for. For example, a Hmong with epilepsy may consult a priest for a cure, since it is believed to be caused by the spirits. It is important to understand that many cultures use remedies other than pharmaceuticals to alleviate symptoms and cure illness. It is important to know that these exist and that people may use them, even if they won't admit that they do. In the case of the Hmong girl with epilepsy I discussed earlier, the Hmong cause of epilepsy was spiritual, therefore the cause was spiritual. And no one thought to ask the Hmong what they thought was causing the epilepsy, and therefore that caused the disconnect that ultimately ended in the tragic death of the child. It's important to know what people believe about illness causation and how they believe it should be treated in order to work with our patients. And the second webinar, which I'll be doing in November, is really going to dive into the topic of folk medicine and review some of these traditional practices. So how do we become more culturally aware? We become more aware by engaging with others in a purposeful way. Here's the process. Start out, if you look at the top of the diagram in the blue box, you start out with respect for everyone in all cultures. Next, you communicate. Ask about preferences, customs. Next, you want to understand. Try to understand other points of view, the ways that people from other cultures look at the world. And then in the purple box, engage. Engage everyone and be curious about people and cultures. Ask about differences. Gain comfort and experience talking with people about culture and cultural differences. You won't know unless you ask. And I should say here that there are many models of cultural awareness consisting of different things. I like to keep it simple, and these 4 stages work well and are clear and easy to remember. You'll also hear it called many things. You'll hear it called cultural competency, cultural sensitivity, and cultural awareness. I like cultural awareness as the term to use for this kind of work. So let's now talk a little bit about cultural brokerage. Cultural brokerage means building a cultural bridge between people from different diverse communities and mainstream health services. Cultural brokerage helps traverse an unfamiliar system and situate what is happening in terms they can understand. And as we discussed earlier, many cultures have explanatory models for health and illness causality that differ from the biomedical health system. These differences need to be bridged or brokered to ensure that patients can fully engage in the biomedical healthcare system without abandoning the cultural beliefs from their own cultures. A prime example where cultural brokerage could have helped is in the Hamon example of the child with epilepsy. Had someone from the hospital worked at brokering an understanding of epilepsy and its treatment that fit in with the worldview of the Hamon's family and also encompassed the biomedical aspects of seizures, the outcome for the child might have been very different. The concept of cultural relativism, as you may recall, means that every culture is equally important. So it is important to understand different cultures and worldviews and broker understanding. It isn't realistic in a diverse society to expect everyone to believe the same or conform to the ways of the dominant culture. There sometimes needs to be a middle ground or compromise that needs to be brokered or negotiated. So I'm going to give you a cultural brokerage example from my own practice. As was noted in the introduction, I'm also a registered nurse as well as a medical anthropologist. And during my nursing career, I worked in the newborn nursery at a hospital. And at the time I was working at the hospital, I already had a master's in anthropology and was well familiar with the concept of cultural brokerage. So on one of the shifts, we had a family of Middle Eastern heritage come in after the birth of their first son. In their culture, firstborn males were very important and thus needed to be blessed by the imam with honey to ensure a sweet life. And this involved putting a drop of honey on the infant's tongue as the first thing they taste. So when their father and the imam came to the nursery to pick up the baby and take it to the mother's room for the blessing, they were told that the baby needed some tests and thus had to stay in the nursery. The father was upset since by the baby staying in the nursery, the first feeding or the first thing that passed the baby's lips would have been administered by the nurses and not by the imam. So the father was upset since the first taste the baby had must be honey in order to assure a sweet life for him. I heard about the situation and I was able to broker a solution that was acceptable to both the physician and the family. The baby received the honey blessing, was tested and found to be healthy and was discharged home. The physician, who was Cuban American, was satisfied and said that she didn't realize the importance of the honey blessing to the family until I explained it to her and helped broker the compromise. At the time of this occurrence, cultural awareness training was not being done for nurses or physicians. My training as an anthropologist helped me broker this compromise. And the article cited at the bottom of this slide is the article that I wrote about this experience. And basically what happened was the doctor said she could not condone the honey blessing. She was worried about the purity of the honey. The imam assured that it was a special stock of honey that he kept just for this purpose. And so the doctor said, well, I can't approve it, but what happens in the room, I can't control that. And if I don't know about it, then I'm not going to worry about it. So she agreed to let the baby be taken out to the parents' room. So I took the baby out, and I was told the parents, I'll be back in 15 minutes. And when I came back, everybody was smiling. I took the baby back to the nursery. The baby turned out to be healthy and was discharged home. So this is an example of cultural brokerage. The baby got the honey blessing. It didn't impact his health. It was very important to the family, and everybody was satisfied. And the interesting thing was that the Cuban-American physician and I had spent many hours of downtime talking about the cultures and traditions that she was raised with, being from Cuba. And so it was interesting that she, of all people, resisted this solution. And it was only after the brokerage that she realized how important cultural traditions are. And she said, gee, had it been my situation, I might have felt the same way. So it worked out for the best. If you want to read the details, the citation is on the bottom of this screen, and there's also a reference list included in the slide deck as the last slide. So now I want to turn to talk about what we call the CLAS Standards. CLAS means culturally and linguistically appropriate services in healthcare. And the purpose of the CLAS Standards, these were developed by the government to advance health equity, improve quality, and help eliminate healthcare disparities. And they're a blueprint to implement culturally and linguistically appropriate services. They're guidelines that inform, guide, and facilitate practices related to culturally and linguistically appropriate health care. So health inequities in our nation are well documented, and the provision of culturally and linguistically appropriate services is one strategy to help eliminate health inequities. By tailoring services to an individual's culture and language preference, health professionals can help bring about positive health outcomes for diverse populations. The provision of health care services that are respectful of and responsive to the health beliefs, practices, and needs of diverse patients can help close the gap in healthcare outcomes. The pursuit of health equity must remain at the forefront of our efforts. We must always remember that dignity, quality of care rights are the right of all and not just a few. Okay, so how do we apply CLAS at our work? Remember, our definition of cultural awareness comprises four things: respect, communication, understanding, and engagement. It is important not to stereotype. We can know the basics of various cultures, but those basics are like a cookbook, the basics or a starting point. Experienced cooks often put their own touches on recipes. Similarly with cultural knowledge. While we may know the basics about different cultures and customs, it's very important not to stereotype. Cultural guides are just that, but everyone is different. So don't assume, but ask. CLAS standards remind us to look at the availability of things like a qualified trained interpreter, language phones that will provide interpretation, and knowing how to access or use them when you have patients that need them. CLAS standards, in other words, provide a path or a roadmap to patient-centered care. As you probably have figured out, effective communication is essential in working with people from different backgrounds and cultures. This chart illustrates how important it is to communicate with people at every point of contact. Speaking the same language is not enough. You need to ensure that the understanding is the same. So if we look at the chart, you'll see that effective communication starts from outreach, through scheduling, through navigation of the organization, and that doesn't just mean going through all the different steps, but it means being able to get into the building and find their way where they're going, registration, interaction with providers, diagnosis, and then after the visit. It also includes things like signage, wayfinding, and all of these many things, even being able to find the restroom. Even things like knowing which floor is which. For example, in some countries, the first floor is the ground floor. So if you have a building where the ground floor is labeled as G, someone might push the button 1 and think they're on the ground floor when in fact they have to go down to G. So that's just an example of some of the cultural disconnects. So wayfinding has to be very, very clear. So this chart illustrates how to communicate effectively with people at every point of contact. Speaking the same language is not enough. Think about your work setting and how effective communication might be enhanced using this chart as a guide. This is what the CLAS standards are meant for, to help us make our work settings more open and welcoming to all. Remember that many professions have their own language, particularly a language of medicine. Do not use medical jargon when talking to patients. Don't assume they understand. Just because they nod their heads or appear to be listening doesn't mean they get it. As part of effective communication, it is essential to understand that many people are anxious, worried, and afraid of going to healthcare settings. Even those who are health professionals themselves can have difficulty hearing and communicating when they are in the patient role. You might even want to use methods such as a secret shopper to traverse your workplace from door to door to see what they encounter. This can provide insights on what might be needed in order to enhance communication in your workplace. So speaking of communication, it's also important to be aware of these aspects of culture and communication. For example, conversational style and pacing. In some cultures, people speak very fast, and in others, they don't. So even speed and rapidity of conversation is important. Personal space. Personal space means the distance between people and how much space around them is considered their own. The culturally acceptable distance between people when talking matters. Think about the term being in your face. In some cultures, it's acceptable to stand very close when talking. In others, it's not acceptable. Eye contact. In some cultures, it's considered rude to make eye contact, especially between women and men, professionals and clients, doctors and patients. This has to do with concepts about deference and even modesty, and also culture. So if you're a male provider, it's sometimes considered rude to make direct eye contact with a woman, especially if there's not a chaperone in the room. Touch is another communication thing. In some cultures, it's acceptable to touch someone on the arm, put your arm around them. Other cultures, touch is not considered acceptable. Part of touch is hand gestures, and this can be very tricky. I know in our culture, people like to make hand gestures, thumbs up and pointing. Well, in a lot of cultures, thumbs up is considered a rude gesture, as is pointing. So be very careful when you're giving someone directions. Be careful about pointing, especially with your index finger outstretched. And remember that thumbs up can be misunderstood and can be considered rude, and in some cultures even obscene. Hand time is another issue that can be tricky. Some cultures, time orientation is big. Other cultures, people are not so fastidious about the clock, therefore they may be habitually late for appointments. And gender norms, issues of female modesty, chaperones, and even males taking care of male patients, females taking care of female patients, may be part of it. So all of these things are important. And if you remember the key aspects of cultural awareness, respect, communicate, understand, and engage, you will be able to bridge the cultural differences between yourself and your patients. So in summary then, how do we become more culturally aware? By engaging with others in a purposeful way. So here's the process. Start out with respect for everyone in all cultures. Communicate. Ask about preferences and customs. Understand. Try to understand other points of view, the way other cultures look at the world. Engage. Engage everyone and be curious about people and cultures. Ask about differences. Gain comfort and experience talking with people about culture and cultural differences. You won't know unless you ask. So to help you, here's an acronym, Be Safe. And it's an acronym to help you remember how to work with culturally diverse patients. Knowing a population and the important aspects of their culture is important. So the first letter B is for barriers to care. The provider should be aware of possible barriers to care for patients in their service area. This can include like language, economic, cultural issues, even things like accessibility of transportation and child care. E stands for ethics. Demonstrate mutual respect to all patients. S stands for sensitivity of the provider. Know your own personal biases and try to overcome them by learning about other cultures and traditions. Providers should try to learn about cultural traditions of their patients, show empathy, and maintain privacy and confidentiality. Assessment. It is important to focus on the whole person during the assessment, including their cultural needs. F is for facts. Know the facts about your patient and HIV and how culture, age, sexual practices, economics, and drug use may impact them. Ask about cultural practices. Most people are happy to talk about their culture and traditions if you ask them. And E is for encounters. Provide patients with information that is simple and clear and make sure they understand. Use teachback or an interpreter if necessary. Pay attention to body language, tone of voice. Also be aware of issues such as the need for chaperones. Many people will nod their heads to acknowledge you when you speak to them out of respect, but that doesn't necessarily mean they get what you're saying. The crucial questions in the next slide can help you find out more of these be safe elements. It's important to understand that a diagnosis of HIV or AIDS carries fear and stigma that may interfere with patients seeking care. So Arthur Kleinman, a prominent psychiatrist and medical anthropologist at Harvard, has worked to understand cultural perceptions of health and illness. He suggests asking patients these 9 questions or variations of these questions in order to understand their perceptions about the cause of their illness. It's important to understand how patients conceptualize their illness. Also, it's important to acknowledge that many people rely on traditional medicine in order to nourish their psychospiritual needs as well as their curative needs. These questions can help you do that. You don't need to ask all of them. Pick 1 or 2 that you feel comfortable to start with. You won't know unless you ask. The video clip you will see next illustrates the importance of becoming culturally aware. Today's session was a starting point on the journey towards becoming culturally aware.
Hi, I'm a physician and I'm here to tell you that health disparities matter. African American men die on average 10 years earlier than white men in the city of Chicago, and that disparity has persisted for 20 years. It's time to do something about it.
Once a Russian-speaking woman came into our office with a letter in Russian, and she asked us to translate it into English and send it to the local hospital. The letter said, "When the hospital asked my older child to translate for the birth of my new baby, I felt like an animal, zvier. But later, when the hospital offered me an interpreter for the birth of my next baby, I felt like a real person, nastoящий человек."
You know, oftentimes providers, I walk into a training room and they think that what I'm about to tell them is irrelevant and completely peripheral to the real work. And I tell them what I'm about to talk to them about, that cultural competence is as important to the outcomes of their patients, is as important to the mortality and the morbidity rates as anything that they're going to do in terms of pharmacology or surgical procedures. In order for a patient to be healed, several things have to happen. They have to come to the medical facility. They have to give a complete and accurate medical history. The provider has to order the correct diagnostic tests, and then the provider has to make the correct diagnosis and develop the best treatment plan for the patient. And the treatment plan has to be one that the patient understands and is motivated to follow. All of those steps require a good relationship between the provider and the patient. It requires trust, and that is completely dependent on the cultural competence of the provider.
What we've seen, for example, within the Latino population in an area of New York State is their lack of awareness to language access resources. So not being able to communicate with their providers, it causes a barrier which contributes to health disparities such as not seeking preventive care, not finding somebody who would be able to deal with primary issues, but unfortunately having these medical issues escalate to a point that they become one of the statistics that are recorded in health disparities issues.
Cultural competence and language access matter. We've heard it all. 2 cases of children as young as 3 being asked to interpret for their own pediatric encounters. An 11-year-old boy who was asked to interpret for his own mother and told her, "Please don't cry, Mama. They tell me I have cancer." If it isn't culturally and linguistically appropriate, it isn't healthcare.
America's a country that's getting more diverse every day, and that's a challenge for healthcare organizations. Doctors, nurses, they want to treat people the best way that they possibly can, but they don't always know how to do that. And the great thing about the CLAS Standards is that they provide a path, a journey, a roadmap for getting to better quality care and to really deliver care that's very patient-centered. And when hospitals and doctors can do patient-centered care, that means that not only do diverse populations get to be healthier, but everybody gets to be healthier.
So if you want to learn more, there are many books I can recommend. Here are a few of my favorites that you might want to start with. Some of these, such as The River and AIDS and Accusation, are about HIV and AIDS. The Spirit Catches You and You Fall Down is the book I mentioned earlier about the Hmong girl who had epilepsy. Mountains Beyond Mountains is a very inspiring book about the work of Dr. Paul Farmer, who works with HIV and AIDS patients in Haiti. The last 3, Walking Over Medicine, Ethnomedicine, and Cultural Sensitivity, are more general books about culture and health beliefs. If you want to continue on this journey towards cultural awareness, I would highly recommend reading at least one of these books, and you might want to start with The Spirit Catches You and You Fall Down. You'll never think the same after you read it. So here's those same books as a reference list. You can, it'll be on the the handout downloads. And as a review, in this session, we defined culture and talked about worldview as a key concept in learning about culture. We also talked about the CLAS standards and the importance of integrating those into professional practice. Thank you for your time.
Thank you, Dr. Deitrick, for a very wonderful presentation. Now it's the time for question and answers. If you have a question, please feel free to type it in the speaker question and technical box located right below the public chat notice. We'll give some people time to answer those or ask those questions. In the meantime, I do have 2 questions for you, Dr. Deitrick. The first one is the CLAS standards that you mentioned in the presentation. Can you tell us where we can get more information about these standards?
Yeah, the CLAS standards are included in the handouts that you can download here. And also if you go to the Think Cultural Health site, you can get them there.
Okay, great. Just a reminder, if anybody has any questions, that you can feel free to type them into the speaker question. Dr. Deitrick, another question that came in is, where can I find out more about health beliefs and people from other cultures?
Okay, to answer your question about where to get more information, if you look at some of the books in the list that are available for download, you can get them there. Plus, I would highly encourage you to tune in to the second webinar in this series, where I'll talk more about traditional medicine, things such as voodoo in Haiti, and a number of things like that that are going to really help us understand the breadth and depth of information. Plus, there's also a number of websites, or they can contact us and we can provide them information as well.
Great, thank you. Again, just a reminder, if you have any questions, to please type them in the speaker question. We were not able to unmute the lines due to background noise. The next question I have is, what do I do if my patient doesn't seem to understand what I'm saying to them, particularly when we're dealing with our populations in South Florida, such as the Haitian population or Spanish population?
Well, the part of the CLAS standards is to make sure that proper language support is in place. And by language support, I mean such as trained interpreters, not children or relatives, but actual trained interpreters that are available. There's also special telephone lines that you can get called language lines that will allow two people to dial in. The patient speaks into the language line, it's translated, and then the practitioner can hear what they're saying. And so that's a way of making sure. Also use methods like teachback and things like that. Also, it's important to understand that people are often going to consult their own traditional systems as well as using the biomedical system simultaneously. So it's very important to use some of the questions that Dr. Kleinman recommended to help really see what your patients are doing.
So if a family member, if a patient does come in and brings a family member to translate and asks that that family member be the translator, is that ever a good idea if the patient wants that?
No, it's really not a good idea because often the interpreter, especially if it's a child, really, or a younger person, they may not know the correct medical terms or the correct translation for what's being said. So it's really important to stress that professional interpretation and or language lines are available, and to ensure correct and complete understanding, that really needs to be done. There's ways to articulate that. You can offer them an interpreter and say, well, you know, let's just use the interpreter and things like that. That's really a question we can talk about more offline, but there's ways of working that out. But I think if your organization really implements CLAS standards and really works to make sure that communication is optimized, make sure you have interpreters, make sure you have language line. Don't call on another employee who knows the language to interpret. There are interpreter training programs, so if you do have employees who do want to serve as interpreters, make sure they get trained, because just because someone speaks another language doesn't mean that they know all of the medical words, body words, and things like that that are essential in really making sure communication is effective.
Another question is there a time when we should stop what we're doing, such as intensive adherence counseling, due to their own cultural beliefs, especially with HIV and AIDS and the fact that medication, Western medication seems, and adherence to medication is so critical?
Well, I think it's important to really ask questions. I think that, you know, it's easy for us as professionals to make the assumption that biomedicine is the best, and you know, sometimes you may want to think, well, gee, why aren't they taking their medicine? Why aren't they doing what we tell them to do? And we may not realize that our patients may be consulting a practitioner from their own culture at the same time that they're seeing us, and they may be using herbal remedies. Maybe they're using special teas, special treatments, things like that. So it's really important to maybe take the time to step back, have a cultural conversation, ask the patient what they're doing, and ask them what is their understanding of what's wrong with them? What do they think caused it? And what do they believe is the best way to treat it? Because if you ask those questions, then that's going to help you get to the root of what the patient's cultural understanding is, and then you can broker a solution from there. It's possible to do this. It just takes practice. And the main thing is you can't be afraid to ask. People want to talk about their cultures.
Okay, thank you so much. One last question before we close out, because I know we need to do some closing issues, but can we contact you if we are presented with a specific case?
Of course. Yeah, we'll be happy to see if we can help them.
And the best way to do that would be contacting you through?
AETC, through our website.
Okay. Doing a website consultation on the Florida Caribbean AETC website.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center Project ECHO provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/ECHO to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.